Hello, I'm Lucy Savitz. I'm a professor in the Department of Health Policy and Management at the University of Pittsburgh School of Public Health. I also serve as the Senior Innovation Advisor in UPMC's health plan. And I'm really pleased to be with you today to talk about the work that I've done in emerging models of care for individuals with multiple chronic conditions. So some key points I'd like to cover with you today so you'll know what to expect. I'd like to talk about what we've learned in exploring high-value models of evidence-based care. Next, we'll talk about some leading efforts in identifying a path forward for health services research, and stop and pause a little bit and think about how does mobility fit in and has it fit in the past? And lastly, what research is needed as we move forward. And before we launch into what do we know, let's talk a little bit about considering the impact of managing chronic conditions and how we got here. In the mid-2000s, I was employed at Intermountain Healthcare. And Intermountain Healthcare is one of the leading health systems in the country, and it's always been known because of its IT architecture. And basically, we had registries, very advanced registries, that supported each of our clinical programs, which were akin to service lines. And so we had a data registry for cardiovascular patients. We had a data registry for diabetes patients, et cetera. And when you think about it, this kind of siloed approach didn't give us a really good view or insight into the care burden that our patients were experiencing. And again, in the mid-2000s, 2008, 2009, the country was, really excited about the prospects of healthcare reform, payment reform. And at that time, Intermountain was one of the leading systems that brought together a group of 19 health systems across the United States called the High Value Healthcare Collaborative. And the HVHC was really interested in having a voice for health systems in payment reform. At that time, we also created a data trust where we brought our data together so we could look at what are the cross-cutting issues. And one of the cross-cutting issues many people were really focused on allowed us to take a population health view. And in taking that view, we were able to sort of subdivide the patient populations that were representing 1 to 5% of the what was deemed at that time, and was, apologetically a rather pejorative term, the high utilizers. And the four sort of groups or subgroups that we saw were sick premature infants, end-of-life care, people with multiple chronic conditions, and sort of the last subgroup was those people who had sort of social risk factors. And this was important for us to really understand. So instead of looking in these silos, we were understanding that people with multiple chronic conditions needed a different kind of care delivery that was more integrated. There are a variety of models that people looked at that time. Now let's think about where we're at today. So today, we know that 1 in 4 adults live with multiple chronic conditions. 2/3 of those adults are Medicare beneficiaries, and 75 cents of every dollar spent on healthcare in the United States is dedicated to providing care for people with multiple chronic conditions. The demographics are not working in our favor. As you see here from the slide, the largest proportion of people living with multiple chronic conditions are over the age of 65. In 1990, there were 3.1 million individuals over the age of 65 in the United States, which was about 4% of our patient population. In 2020, it was 56 million, now 17% of the population. And in 2040, it's estimated that 81 million individuals will be 65 or older. So what I would conjecture here is that our healthcare system and our economy is not really poised to deal with the burden of care that's sort of coming our way. And that's something that we have to really think about. The other really important issue when you look at the data is that there's a widening gap when you look at those individuals with multiple chronic conditions and measures of longevity or active life expectancy, that those gaps are widening when you look at race ethnicity data or socioeconomic data. So there are important equity concerns that we have to consider as we're moving forward. But moving forward, a lot has been happening more recently, and I'd like to talk with you a little bit about what's been happening recently and I've been involved in. So the Agency for Healthcare Research and Quality, or AHRQ, is really the only federal agency that's funded by the federal government to look at the way healthcare is delivered, if you will. And a good friend and colleague, Dr. Arlene Bierman, who is a really transformative thinker, has really focused a lot of our strategy in thinking about how do we transform care for people living with multiple chronic conditions. And as part of that effort, she commissioned a special issue of Health Services Research. There were 3 papers that were commissioned under contract with AHRQ. The first one looked at high value or emerging models of care for people with multiple chronic conditions. The second paper really focused on healthcare information technology solutions to improve care for these individuals. And then the last paper was really sort of a scoping review that looked at person and family engagement in the context of living with multiple chronic conditions. But what I'd like to spend a little bit of time talking about is the work that I did with my colleague, Elizabeth Bayless. And in looking at emerging models of care, our objective was really to characterize the emerging and current practice models that were being used to effectively treat and support patients with multiple chronic conditions. And so we started where any good health services researcher starts. We started with the peer-reviewed literature, and we did a rapid literature scoping between January of 2015 and April of 2020. So it's a 5-year time period. We identified 14 studies for in-depth review. And of interest, I think, to this particular group, only 4 of these studies reported outcomes related to functionality or quality of life. And we found insufficient evidence to guide, identification of some high-value model or magic bullet that could be used in care delivery, either focused at the individual level or a population level. So we decided to look at other sources. And one of the things that we were able to do was to leverage some relationships we had with health systems across the country. I already mentioned the High Value Healthcare Collaborative in 2008 that we helped create. And we identified within those health systems, 9 health systems that represented all the US Census regions and practicing clinicians who had expertise in treating patients with multiple chronic conditions. And we did a series of key informant interviews. So each interview was between 45 minutes and an hour. And we really prompted them around what were the things that they were doing that were innovative in caring for this patient population. And you can see the listed themes here on this particular slide and the number of respondents who indicated that they had been looking at it. So almost universally, everybody's looking at patient-centered approach. Then the next group that is, everybody reported looking at was complex care, and especially including social risk factors in these considerations, particularly as it relates to treatment planning for these individuals, but also other themes that really the kinds of things you'd expect. A focus on transitions, incorporating community, population management perspective, IT tools that can help, particularly around predictive analytics, for example. Financial incentives, reimbursement, and ROI, sort of the catch-all category of everything related to money. And then lastly, the importance of research or evidence-based practice. And one of the concerns, remember, we were conducting this study during the COVID pandemic. These interviews were done in October of 2020. And as we all know and experience, many of our health systems had put in policies around, elimination of elective procedures care, trying to keep people out of the hospital unless it was absolutely necessary. And one of the things that everybody experienced was this sort of rapid uptake of telehealth that had not been previously used. There are lots of other, remote monitoring devices, home-based care, hospital at home care that were put in place without evaluation. And so I think that there's a lot of evaluation that needs to happen as we're thinking about what's going to stay in place after the emergency authorization ends on May 11th. And then the other thing that I think is important to note is that this work was done within the context of a larger groupthink process. So we had a planning meeting about transforming care that was held in May of 2020. And there were 75 individuals that attended that meeting and gave feedback on our early thinking about how we would approach our commission paper. And then in 2020, the actual research summit was held in November, where 133 people attended and gave us feedback on our final results as we were laying them out in that paper. And these audiences were incredibly varied in terms of the perspectives they brought to the consideration. There were policymakers, there were funders, government representatives, health services researchers, payers, senior leaders in health systems, patients and patient partners, technology company representatives. So there was a very broad range of perspectives looking at this work and trying to inform the way we were thinking about things. And one of the quotes that really has stuck with me that came out of the key informant interviews that I think is important for us to think about as we consider caring for people with multiple chronic conditions is that sick care hasn't really helped people manage their lives outside the bounds of our care delivery system. That's a really important observation. And this particular individual went on in their comments to note that, if a person managing multiple chronic conditions touches the healthcare delivery system in some way, whether it's an ED visit, whether it's a primary care visit, whether it's a specialty visit, whether it's a hospital admission, maybe they touch the health system 20 days a year. That leaves 345 days a year that they're outside of the walls of our hospitals and clinics and caring for themselves and self-managing. And so we have to really think about, if we're transforming care delivery, should we really be focusing those resources on sick care, or focusing our resources on how to keep people healthy, how to achieve longer lasting active life expectancy where they don't really need assistance and they can live independently, presuming that that's their personal goal. One of our other key informants noted that patient-reported data on function and well-being, coupled with newer dynamic modeling techniques around predictive analytics, for example, may better identify populations at risk for future healthcare utilization. And I think one of the things in looking at the literature, in thinking about the work that you all are doing, I really didn't see much of a focus in the literature on function and well-being. And I think that's an important missing element in our consideration of how do you put these models in place, and what are patients wanting in terms of their own personal goals related to active life expectancy as an outcome measure. So the work at ARC continues. And they continue to evolve their research agenda. And I'd suggest that you go to their website to look at funding opportunities in this area. And while the aging population has always been a priority population, ARC has really, sort of honed in on this group of people who are managing multiple chronic conditions. There was a request for information on person-centered care planning for these individuals that went out in the Federal Register earlier this year. And the responses came in and were then used to plan a roundtable that was held on April 11th, where the topic of the meeting was optimizing health and functional status as we age. And the goal of that meeting was to really think about, how do we improve care delivery to optimize health, function, and well-being in an aging population? So again, it's not just focusing on life expectancy, but also active living expectancy as we think about how do we move forward. And I don't need to tell people in this audience about why is physical activity important. But it does bear repeating, I think, for any audience that, the lack of physical activity can lead to obesity. And obesity is a primary risk factor for many other chronic conditions: heart disease, type 2 diabetes, depression, and I could go on. But the fact that we haven't really focused on how does rehabilitation medicine and physical therapy fit in to this work is an important gap that we have omitted in thinking about how do we develop emergent models of high value care for individuals. And in 2016, the John A. Hartford Foundation and the Institute for Healthcare Improvement, or IHI, really expanded our perspective to look at the age-friendly ecosystem. So again, we've talked about, highlighted the quote about sick care not being sufficient. So if you think about much of the work that's been done here has focused on health systems, the care that occurs within the healthcare delivery system. And this ecosystem approach asks us to take a much broader view so that we're not just looking at healthcare delivery, we're expanding that to look at the policies and the infrastructures that are built up in our communities that support people living actively and independently as long as possible. And more recently, the Hartford Foundation and IHI, the American Hospital Association, and the Catholic Health Association released a book. I have no particular interest in this book, but it is available on Amazon. And they put out a guide for using what they're calling the 4M framework while caring for older adults. And I highly recommend it. It's a great playbook with a lot of resources that are available in it. But the question that you should be asking is, what does it mean to be an age-friendly health system? So the age-friendly health system really has three aims, that you're following evidence-based practices, that you're not causing any harm, and that you're aligning with what matters to the person and their family or caregivers, and doing so in a reliable fashion based on these four principles or evidence-based elements of high-quality care that are laid out in the report. And these are the 4M framework items. So what matters? What matters to the patient or the person, and what matters to their family caregivers. The second is medication, and understanding when the medications that are prescribed may interfere with what matters to the patient, including mobility, including mentation. And mentation really focuses on how do we sort of help people in various settings of care function sufficiently and cognitively optimized fashion. And then lastly, mobility. So how can adults, older adults in particular, move safely, particularly when they become frail and when the goals that they have are not in alignment with their current physical functioning capabilities. So how can health services research, advance this evolution? I'll give you three examples that come to my mind, but I'm hoping you're thinking of others as we're talking through these issues. One is generating the evidence we need to design and test new models for active living with multiple chronic conditions. And this has to include ROI. Most of the studies done in this space do not include the cost elements. What is the return on investment? In the current post-pandemic era, most health systems have a very low to negligible margin. And you've probably heard the phrase, no margin, no mission. So investments of new models of care, especially when there's costly IT investments, for example, you have to be able to show the return on investment for health systems to be able to make those investments in the future. The second area is around having a more holistic view that integrates self-management and sick care interfaces. There's a wonderful book that was published in 2016, The American Healthcare Paradox. And in that book, they make the point that, health is not equal to healthcare. And we've been talking about, sort of sick care and the problems of just focusing exclusively there. And it's always alleged that the US spends twice as much as other OECD countries. And it's just not simply true. When they combine social welfare spending, public health spending, and medical care or sick care spending, we're middle of the pack. We do not spend twice as much. What we do is we disproportionately invest in sick care. And so thinking about what is it going to take to achieve this age-friendly ecosystem for us to come up with solutions and partner with collaborators and stakeholders in the community, in state and local government, to put resources in place that can really help people live to the fullest potential possible. And then lastly, this expansion of patient-reported data that includes functionality that can be captured to model and explore person-engaged multiple chronic care management services. So I hope that that has intrigued you and brought to mind some comments that you may have or questions that you may have. I welcome the opportunity to talk with you today. And thank you very much for your attention.